webinars and all that, but just being able to be with everybody is so important. So I'm Virginia Steen. I'm a professor of medicine at Georgetown, and I've been in scleroderma research a very long time. Started in, can you not hear me? Can you hear me now? Is that better? Okay. Why is this Mike? Well, they say they can't hear me. I guess that's why everybody's been holding the mic. Does this work better? Okay, all right. Guess that's why people hold the mic then. Okay, so anyway, as I was saying, I've been in scleroderma research a long time. Started the University of Pittsburgh database and have done many other things. But one thing else I did was I had a multi-center pulmonary arterial hypertension registry that the scleroderma US community did for over 15 years. And it really was a wonderful endeavor with a lot of the young, they're not so young anymore, but a lot of the people you were hearing talk over this past few days were one of my very junior investigators when that started back more than 15 years ago. So pulmonary arterial hypertension, along with pulmonary fibrosis, is one of the most common causes of why people with scleroderma die. This is from a study out of Pittsburgh. And as you see, actually, most people with scleroderma die of other things. But when they do die of scleroderma-related diseases, nowadays, most commonly, it's with pulmonary hypertension or pulmonary fibrosis. You've heard a lot about pulmonary fibrosis. Dr. Silver, Dr. Hyland gave very nice talks, and then Dr. Boyne gave the lung transplant talk. So this is now the extra pulmonary talk here. So we're talking about pulmonary arterial hypertension. And I don't think this arrow works on there, so I'm not quite sure. Anyway, over there you can you can see the lungs, and you can see the narrowing of the blood vessels of the lungs in the picture there. And that, when you have narrowing in those lungs, that then puts pressure on the right side of the heart. And this is a normal chest x-ray of someone with pulmonary hypertension. And you see the lungs that are very nice and black because there's nothing you can see in the lungs. There's no scar tissue, there's no infection or anything, but the heart is enlarged. And you can see that particularly because on the right, let's see, I guess it's your left side, but it's on the right side of the heart. The heart is bulging beyond the spinal column, and normally it just sort of starts at the spinal column and goes to the left side of the body. So that shows the heart is clearly enlarged. And the reason this is happening, as far as blood vessel issues, so everybody has Raynaud's, but everybody has cold-induced spasm in their blood vessels. I have cold-induced spasm in my blood vessels. That's a normal phenomena of physiology. And when you have that, normally the blood vessels get narrowed, and that's in the upper hand group. I wish I had a pointer. Maybe this is a pointer. No, okay. And in the lower part is where scleroderma is, and the blood vessels in scleroderma, particularly in the fingers and in some patients the lungs, are narrowed. And so when you have this cold stimuli, they become even more narrowed, and that's why the decreased blood supply happens, and that's why you end up getting Raynaud's. Well, what happens in pulmonary vascular disease and pulmonary arterial hypertension? Again, the upper lobe is the normal one. The normal pulmonary artery has a lot of what we call compliance when it has Raynaud's. We know that there's probably some Raynaud's in the lung, although that's not a primary mechanism of pulmonary hypertension. But when there's increased flow from the back pressure of the patients that have increased pressures in the heart, that normal blood vessel can dilate, and there's no problem. So it can handle the increased blood flow, and that's what they call compliance. But When you have pulmonary vascular disease and you have thickened blood vessels in the lung, those blood vessels are stiff, they're thickened, just like they can be in the fingers. They're very thickened. And when you have increased blood flow, that blood vessel is not able to dilate. And so that causes the heart to work harder and causes the pressures to get higher and cause more problems. So that's sort of the mechanism of how this happens. But again, all is because of the development of thickening of the blood vessels in the heart, excuse me, in the lung. So pulmonary hypertension is not something that happens overnight in scleroderma. This is happening over a long period of time. And the symptoms are really very non-specific. And they can be related to so many different things, as well as different things within scleroderma, such as pulmonary fibrosis. And so the shortness of breath with exertion is probably one of the main first symptoms that people have. But what do people do? They don't exert themselves as much. So they slow down, they don't carry their groceries, they only go up and down the stairs once a day, they don't go to the grocery store. And so they just sort of adapt to it. And they don't recognize that they've really become quite short of breath. And they don't even think about it, so they don't even complain about that to their doctors. And this is going to be one theme that I want you to make sure you understand, that you have to pay attention to your breathing, because when your doctor asks you, are you short of breath? And you say, oh, no, I'm fine. That's not going to help you, and it's not going to help the doctor. So fatigue is another problem, but how many people with scleroderma have fatigue from all aspects of their disease? So that doesn't help us very much. Chest pain's not a big one for scleroderma. With pulmonary hypertension, idiopathic patients with pulmonary hypertension tend to have more chest pain. Cough, okay, cough comes with fibrosis, from reflux, from nasal drip, from everything. So again, that's a very non-specific symptom. Fainting, near fainting, again, this is only when there's really advanced disease, and I don't want anybody to get advanced disease and present with fainting. So sometimes when you have pulmonary hypertension, you can get some heart failure, and that can cause fluid retention or edema. Again, there are lots of causes of edema: hot weather, eating salty foods, being on your feet all day, vein troubles, lots of things. So again, there's lots of reasons for edema, but these are things that you need to pay attention to make sure you let your doctors know. And another thing that we found out is because of the decreased oxygen, even if it's not low enough that you actually need oxygen, it's lower than normal. And so this then, when you develop an ulcer, a finger ulcer from your Raynaud's, that may aggravate it and may make it even harder to heal. So we have found that patients have noticed increased frequency of ulcers around the time they're developing pulmonary hypertension. So again, emphasizing this shortness of breath. And again, it's not something that happens at rest. Generally, people are very comfortable. Their oxygen levels are pretty normal at rest. But that when they move around and with activity, they certainly get short of breath. And this is, again, what I was talking about, how patients adapt to the difficulties that they have, and they may deny. I know my very first patient with pulmonary hypertension that I used one of the drugs that is now still approved for it, Tracleer, and it was more than 20 years ago. She wouldn't admit she was short of breath. And I said, oh, well, I'm going to give you this drug anyway. She came back 3 months later and she says, I can go to church now. I haven't been able to climb stairs to go to church for 3 years. And she said, I never knew I was short of breath. I just didn't want to climb those stairs. So think about this again. This is really important that you share this information and keep this in your brain about how your activity level has changed. Can you do things as easy as you did last year? And again, it's not week to week. This is over a long period of time. This is not just in the past week, but think about how you were functioning 6 months and a year ago compared to how you are now. And make sure you share this information with your doctor. So there are many different types of pulmonary hypertension in scleroderma. The one we hear most about is pulmonary arterial hypertension, because that's the one that has all the many drugs and that we've been focusing on for the last 20 years. But group 2 down at the bottom there is related to heart involvement. And so it's actually the most common cause of pulmonary hypertension worldwide, because so many patients have what we call diastolic dysfunction, which is stiffening of the heart. And so that causes some backup and causes increased pulmonary pressures. Scleroderma patients can get diastolic dysfunction. It's something that happens as one ages. And the separation of whether it's from normal, I don't know what normal, but regular type of diastolic dysfunction or stiffening and scleroderma is really hard to separate. There's no specific treatment for scleroderma diastolic dysfunction, so the cardiologists treat it just as they treated, for any type of heart failure from diastolic dysfunction. But that's also could be related to scleroderma. And then there is lung fibrosis. And so when patients get severe pulmonary fibrosis from scleroderma, particularly in our situation, they get low oxygen. And when you have low oxygen, that puts stresses on the heart, particularly the right side of the heart. And then that leads to increased pulmonary pressures. And so we call that pulmonary hypertension related to lung disease, or group 3 pulmonary hypertension. There's also this blood clots in the lungs. Lupus patients, similar disease to scleroderma, often have antibodies that make them at increased risk for blood clots. And so we have some patients with lupus with overlap with scleroderma can have blood clots in the lungs. So that's a less common, but something that your doctors always have to consider and rule out, because then you clearly need to have blood thinning medications, anticoagulation to treat those blood clots. And there are some specific medicines for that type of pulmonary arterial hypertension. One of the reasons that scleroderma pulmonary hypertension has been a little bit harder to treat, and we'll talk about some of the others later, but is that there's a rare involvement of the veins in the lung in scleroderma. In idiopathic pulmonary arterial hypertension, those veins don't seem to be involved, but in scleroderma, just like the arteries are thickened, the veins can be thickened, and that can cause even further problems and a lot of low oxygen problems, which then multiplies the complications. Fortunately, that's a pretty rare complication, and it's mostly identified by changes on the CT scan, or because the patient is really particularly with very low oxygen, out of proportion to what you would expect them to have. So we just talked about these main 3 ones that we have in scleroderma: vascular pulmonary hypertension with thickening of the arteries, the heart involvement with heart stiffness. Occasionally we can have some heart problems where the heart itself overall is thickened, and we can get congestive heart failure that way that causes pulmonary venous hypertension. And then again, the scarring or the fibrosis. So this is a nice little cartoon here, if I can show this. This is the heart. You see the right side on the bottom and the left side on the bottom, and the right, the blue blood vessels go to the lungs on the left. No, I guess that's on that side. That's the left side. And then the red ones, or the red heart is going to all the arteries of the body. And so when the blood comes from the veins, goes through the right heart and gets to the lungs, that has a certain pressure in the lungs. It's a low pressure system. And when it goes around, gets the oxygen from the lungs, gets into the left side of the heart, so that the heart can then distributed all around to the body. And in the body, the regular blood pressure is there, and that keeps going round. And when you have problems with high blood pressure in the lungs, when the pressure is increased in the lungs, that you can see puts a stress on that right side of the heart, trying to push those that blood through those lung blood vessels that have that increased pressure, which can't, as we saw earlier, don't have the compliance to expand, to dilate. And so that then puts more pressure, and it gets into this vicious circle. So we talked about some of the increased risk factors, but these are some more. We do tend to see pulmonary hypertension develop later in the disease. So pulmonary fibrosis is not almost, but is most commonly early in the disease. We say it usually happens in the first 5 to 7 years. But this form of lung disease most likely happens way after 5 years. Many patients have had scleroderma for 10, 15, 20 years before they have any evidence of developing pulmonary arterial hypertension. It also happens later in age as well. So if you develop scleroderma at age 60, you're maybe a little more likely to get it even at an earlier duration of disease. But this long duration of Raynaud's is one of the clues and one of the reasons we look at patients, even if they've never had severe skin involvement. Some people don't even have any. Some people fit in the category of what we call cine scleroderma, without skin thickening. The subgroup, you've all heard about all of our subgroups and how limited cutaneous scleroderma and diffuse cutaneous scleroderma. More commonly, pulmonary hypertension happens in limited cutaneous. We've tried to get away from this term CREST syndrome just because many patients with diffuse scleroderma have all the manifestations of the CREST as well, but they are not as at high risk for developing some of the features as the patients with limited cutaneous. So we've tried, we haven't successfully done that. But the anti-centromere antibody, again, is the main antibody within the limited cutaneous patients, because there are many limited cutaneous patients that don't have centromere antibody. They have one of the other antibodies. And so there are some limited cutaneous patients that are at increased risk for having pulmonary fibrosis based on their autoantibodies. And the other thing is that some patients with diffuse cutaneous, over time, their skin improves a lot and they look like that they're limited cutaneous, but their overall course of their disease is one that is how they started. So this is, again, more common in limited cutaneous. But patients that are African American or have a certain antibody, particularly this nucleolar pattern antibody, it's not a very common one, but it occurs in about 50% of African Americans with scleroderma. And those patients often have diffuse cutaneous disease. So that's another subset, particularly in the patients that are African American with diffuse cutaneous disease that are at higher risk for developing pulmonary arterial hypertension. And then we've talked about the digital ulcers, but one investigator, Ami Shah, did a study calculating the number of telangiectasias patients have. I can't imagine counting all the telangiectasias patients, but they had a method of doing it, and they were able to show that as the patient developed pulmonary arterial hypertension, they were also developing more telangiectasias. But if you remember, telangiectasias are just dilated little capillaries on your skin. They don't cause disease. They're just a manifestation of having had the disease for a longer period of time. But these are these antibodies. I know Dr. Gordon yesterday showed a lot of pictures of autoantibodies. But the three main ones that we have in scleroderma, this anti-centromere is clearly the most common in the limited cutaneous group. The two other large ones, the anti-topoisomerase or the SCL70 antibody, is the one that's more common in diffuse and with pulmonary fibrosis. And then this RNA polymerase 3, which is the one that's associated with the most severe skin disease, as well as several other problems, particularly kidney problems. Renal crisis is a worrisome manifestation of that form, as well as some associations with malignancy, as well as some association with strange things in the stomach that Dr. Freck may have mentioned, watermelon stomach, or fancy name, gastric antral vascularitis. So each of the antibodies have their own sort of associations, and your doctors, knowing what your antibody is then able to focus their search for different problems. These other antibodies are less common. U1-RNP is the antibody that's associated with what's called mixed connective tissue disease. And this antibody is often associated with overlap with lupus or myositis or rheumatoid arthritis. These patients are also at increased risk for pulmonary arterial hypertension. It's just that it's not as common as an antibody. And the other three ones, again, smaller in frequency, are also, they're the nucleolar pattern ANA that I mentioned. And these antibodies are also associated with quite severe lung disease because they can have both fibrosis and pulmonary vascular disease. So if you happen to have a nucleolar pattern ANA without one of these other three more common antibodies, those you're at increased risk for lung disease. So we talked about shortness of breath. Another risk factor or abnormality is seen on echocardiogram, and that shows up as increased pressures or increased pulmonary artery pressures in the lung on the echo, but it's an estimated, and we'll talk about that. But the thing that I have focused on, because it's a relatively easy test to do, are the pulmonary function tests. And we get pulmonary function tests in all of our scleroderma patients because they tell us not only about pulmonary vascular disease, but they tell us about pulmonary fibrosis. And long ago, when I first started studying this disease, I recognized that patients that had pulmonary hypertension diagnosed, they had a very low diffusing capacity. And the diffusing capacity is just one of those tests, and they measure how much carbon monoxide crosses the blood interstitium and alveoli membrane there. And so if you have a thickened membrane there because the blood vessel is thickened, then your DLCO is going to be lower. And that's what we saw. And also because these patients did not have significant fibrosis. When you have fibrosis, the forced vital capacity, and I know Dr. Silver told you all about the forced vital capacity, that's the main pulmonary function test that shows how much scar tissue you have in your lung. And because pulmonary arterial hypertension patients don't generally have a lot of scar tissue, that ratio of the forced vital capacity to the very low DLCO is quite high. And so these are clues that, we can use to develop whether you're at increased risk. And I know all of you have had pulmonary function tests, but the challenges with pulmonary function tests is that the technician has to be a driver. And so if the technician just says, oh, take a deep breath and blow out, your measurements aren't going to be realistic. I mean, they have to yell out to you, breathe, 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 breathe. And if they're not doing that, and then they say, oh, there's something wrong with your test, maybe it's the technician that's doing the problem. So we've talked about the forced vital capacity and measures how much air you can get in. And if there's a lot of scar, you can't get in as much air. And so that lowers the forced vital capacity. And the diffusing capacity, the DLCO, measures whether oxygen can diffuse from the air cells when you breathe in into the bloodstream. And if you have fibrosis, that can decrease that because that membrane's increased, or if you have the thickened blood vessels. And so there are at least two reasons that the DLCO is going to be low. But if you have a normal forced vital capacity because you don't have fibrosis, and you have this low DLCO, that ratio is going to be high, and that's going to give your doctor a clue that you might be at increased risk for pulmonary vascular disease. So we did a study, and we had the Pittsburgh Scleroderma database, which had lots and lots of patients, and we looked back at patients with scleroderma who had developed pulmonary hypertension and those who did not. And we matched them to the type of scleroderma they had and the autoantibodies. We tried to make them very similar, and then just looked at what their DLCO was 4, 5, 6 years before they developed pulmonary hypertension. And as you can see, in the patients that had pulmonary hypertension, 4.5 years before they had pulmonary hypertension, their DLCO was 52% predicted. That then really told us that here we were 4 or 5 years before they had any documentation of pulmonary hypertension. Most of these people had normal echoes at this time. And we know those are the people that are going to be most likely to develop pulmonary arterial hypertension. So that's the group we can really focus on now in doing the regular screening echocardiograms. And this is what happened as far as their development of pulmonary hypertension over that 5-year, 10, 15-year period. They started out normal 15 years before they developed. These were people that had pulmonary function tests in each of those time periods. And then over time, they developed decreased DLCO and developed pulmonary arterial hypertension. So that's a very good clue. And when we did this study, and I mentioned to you earlier about pulmonary hypertension registry, it was called PHAROS, and we ended up with some 250 pulmonary arterial hypertension patients from the US, and less than 5% of those patients, only those green dots on this side of the red line, had a DLCO that was greater than 70% when they developed pulmonary arterial hypertension. So this was a really good clue, and actually all but one of those patients, within the next time they did their pulmonary function test, it was below 70%. So if your pulmonary function tests show your DLCO is greater than 70%, you're at that point and you have 10 or 15 years of disease, that means you're at a pretty low risk, as opposed to if your DLCO's 50% and you have 10 years of disease. That means you are at increased risk. And so that's when we do the echocardiogram. And so this is the sound wave test. Again, hope all scleroderma patients have had echocardiograms. But there are challenges with echocardiograms, as there are with all tests. It is the screening test of choice. Pulmonary function tests are not a screening test for pulmonary hypertension. They're a screening test for whether you're at risk for pulmonary hypertension. So it's a little bit different there, but the pulmonary function test can't tell you whether you have pulmonary hypertension. So we have to screen with the echocardiogram. But the way they calculate the pulmonary artery pressure is only an estimate. So they measure a certain way that the blood flows through one of the heart valves that suggests whether the pressure is increased. And then they have to multiply it and square it and do this formula to get the estimated pulmonary arterial hypertension pressures. And so if you have just a millimeter measurement error, that's going to make the estimate of the mean pressure much different. And so false values are quite common, and we've learned that we cannot depend on the echocardiogram as the be-all and end-all for the measurements of pulmonary pressures. And then, of course, as we talked about, there are other causes for increased pulmonary pressures. It's not just pulmonary arterial hypertension. So everybody that has an abnormal echo that shows an increased pulmonary pressure in the heart needs to have a right heart cath. And the right heart cath is really the gold standard for making the diagnosis of pulmonary arterial hypertension. And yes, it is an invasive test. They do have to put a catheter, usually in a vein in your groin or in your arm, and then they stick this catheter, push this catheter to measure the artery pressures in the heart. It's not like doing coronary artery studies where they put dye in to look at the actual coronary arteries. So they're not going into the very fine arteries there. They're just going into the different chambers of the heart. All tests have some complications, but this is really a pretty easily managed test without a lot of complications. And one more test that we do, which is really mostly, I think, to monitor your response to treatment, but also to measure your oxygenation while you exercise. And this is called the 6-minute walk test. And this is you're asked to walk up and down, usually up and down a hall, and sometimes you run into patients and janitors and everything. So there's problems with that as well. But when you're doing that, one of the biggest problems is if they use the finger probe, you walk and you exercise, and what happens to your fingers when you exercise? Your Raynaud starts to happen, the blood vessels clamp down in your hands, and they go to the muscles. They want all that blood to go to the muscles while you're walking. So if somebody tries to do a 6-minute walk and they put this finger probe on your finger and say, oh, you don't have any good oxygen, you just tell them, well, I have Raynaud's, that's why. And they, oh, really? So it's really important. The amount that you walk is affected by different things. You can have joint problems from your scleroderma, skin problems from your scleroderma. You're maybe a little older and you have arthritis. Maybe you're anemic, and that interferes with how much you have energy and muscle weakness. All of those things can contribute to the 6-minute walk, but it does give us a good idea from visit to visit, or 6-month visit to 6-month visit, whether there's a major difference in both your oxygenation while you walk that 6 minute or the distance that you walk, and how short of breath you're feeling. Because after you do the 6-minute walk, they'll ask you on a scale of 1 to 10 how short of breath you are. So that's something that is very important for us. So as I said, it's really important to screen all scleroderma patients for PAH every year. But how you do that really depends on what your risk is. So if you're somebody that has diffuse disease, very early disease, a normal DLCO, all you have to do is talk to them. You might not have to do any more testing. But if you have high-risk patients, if you have a low DLCO, then you need to do the echo pretty much every year. And this is, again, where you come in, because if you have changes in your breathing ability, in your endurance, in your ability to do things, this is where you need to tell your doctors so that they can say, yes, that means maybe there's an increased problem and we need to redo the echocardiogram. So studies have been done showing the difference in outcomes in patients when they are diagnosed with pulmonary arterial hypertension, when they're screened aggressively, compared to those that present to pulmonary physicians through routine practice. This is just one of the studies that is from France. And you can see that top line, the survival of patients with pulmonary arterial hypertension is much better when they're identified early. And this is, we've really, as you'll hear in a minute, we've really turned this into just a chronic disease, whereas previously, again, like before we had any treatment, and even in this study, even though there was treatment, because patients came so late in their illness, they had a very poor outcome. So pulmonary hypertension treatment has really been probably the most exciting thing that has happened in scleroderma over the past 20 years. I'm sure Dr. Gali Boswick will be talking about it in her keynote talk in a little while. But when I first started in scleroderma, there was no treatment. It was really the only thing that I had in any of rheumatology, where when the patient came in and we made this diagnosis, we said, we really have nothing for you at all. And that was really true. And most people really barely lived even 2 years at that point. And it was really awful to see. We kept trying all these different things. Well, finally, now it's been probably 25 years ago that the first treatment was identified and made a world of difference. And so we have 3 different pathways, and I'm not going to go through these because they're all very complicated, but there are 3 different pathways. So you could potentially have drugs in one of each of these 3 pathways. The first pathway that we found that was worked was called prostacyclins, and those are very potent vasodilators, so they dilate those blood vessels in the arteries. The other one is the nitric oxide pathway, which works through a different mechanisms, but it also works to dilate blood vessels. And actually one of those drugs, sildenafil, is now a very commonly used drug, even though not officially approved for Raynaud's, but it's a very commonly used drug because it's off patent and it works very well and is well tolerated for Raynaud's and scleroderma patients. And then the other drug pathway is called the endothelin pathway. Endothelin is a chemical which is a very potent vasoconstrictor. It's very potent. And so when you block that pathway, that constricting doesn't work, and so it can dilate the blood vessels. So we now have 14 different drugs that are available for the treatment of pulmonary arterial hypertension. It's really been a very exciting time. We have 3 different drugs in the endothelin pathway. We have 3 or 4 in the nitric oxide pathway. And then we have a bunch in the prostacyclin pathway, given different ways. There are several of them are now that are oral medications you can take by mouth. Some of them are underneath the skin or subcutaneous, and some of them are intravenous. Some of them are inhaled. So we have a lot of different methods and different ways of doing it. Well, overall, in general, the comparison of patients with scleroderma and idiopathic pulmonary arterial hypertension, the response to treatment has not always been as good as these idiopathic patients. And we've looked at many reasons why this is. And one of the reasons is that our patients tend to be older. Idiopathic patients tend to get this disease in their 40s. And so we have studies that in our Pharos studies that more than half of the patients with pulmonary arterial hypertension actually died of other things. So instead of everybody dying of pulmonary hypertension within 2 years, we've now changed this so that you can get hit by a truck, or they can get cancer, or they get an infection, or whatever, but they don't necessarily die of their pulmonary arterial hypertension. Also, scleroderma patients may have some confounding interstitial lung disease, even though that's not necessarily the primary cause of their pulmonary arterial hypertension. It may contribute to having more problems. They could have regular old left heart disease. They could have some coronary artery disease. They could have some diastolic dysfunction, just because they tend to be in the older age group. So there's lots of different things that can happen with that. There's also been really lovely studies out of Hopkins. Dr. Paul Hassoun has really focused on the right side of the heart, thinking that in scleroderma there's something else going on in the right side of the heart. And he's found that it does not have as much muscle function as it should in comparison to control patients. So there's more difficulty with that. The blood vessels that are thickened in the lung are thickened similarly as in idiopathic pulmonary fibrosis, but the outer layer of that thickening is much harder, so that there's more scar tissue in the outer layer of that, making that blood vessel even less compliant, less able to respond. And then, of course, there's aging type of problems with musculoskeletal problems, deconditioning, and probably the biggest problem is poor recognition in the community, leading to later diagnosis. And that really is the biggest challenge. I mean, I've worked very hard for the last 20 years in my Washington community, and I think my rheumatology, general community rheumatologists do a great job of monitoring. But what I'm seeing are people that I diagnosed 15 years ago, limited scleroderma, showed they had a low DLCO, told them to go to their doctors, told their doctors to keep screening them. Well, they didn't go back to their rheumatologist because they were doing well. They went to their primary care, and their primary care didn't know what they were doing as far as scleroderma goes. And they never were tested again. And then they come back to me and they have severe pulmonary arterial hypertension. And you totally miss the chance to make that early diagnosis. And then they don't do as well, unfortunately. So again, management for you, because you are the main manager of a lot of your symptoms and problems. And I know you have a lot of things, but if you have breathing problems, that's really important that you talk to your doctors and be attentive to your symptoms. If you do have pulmonary arterial hypertension, make sure you work very closely with both your pulmonary hypertension doctor and your rheumatologist. Generally, that's not a problem because the pulmonary hypertension doctor doesn't want to have to deal with your GI stuff and your Raynaud's and your other things that go along with having scleroderma. But make sure you keep that whole team of doctors. Because if there are other new sclerodermas, just because you have pulmonary hypertension doesn't mean you can't get other problems. You can't get other scleroderma problems, but those need to be treated aggressively and early. And then I know there's a lot of hesitancy to take a lot of medications, but we know that these medications, and they're hard to take. They're not easy medications to take. They have side effects, but they really have made a major difference in it. So early diagnosis and treatment really make a difference. And I'm just going to show you this graph. This bottom line, this straight line, which I told you about, was pre-drug from the University of Pittsburgh database. So basically, everybody died by 5 years. In the Pharos study, the top line, the green line, at 5 years, 76% of patients were alive and dealing with their pulmonary arterial hypertension. There were another 10% that died during that time, but they died of other things. And they didn't die of their pulmonary hypertension. They died, as I said, they developed cancer or coronary artery disease or other complications of their scleroderma. And then the pulmonary world also had a registry of pulmonary arterial hypertension from the pulmonologist standpoint. No rheumatologists were in there. And when you look at their scleroderma patients, their 5-year survival was 40%. So it really makes a difference when we as rheumatologists identify this in scleroderma patients, and we can treat it and make it into a treatable, manageable disease. I have patients that were in this Pharos registry. As I said, we started this in 2005, so 18 years ago, and they are still coming to my clinic today and are managing. So it really does make a difference. So we've talked about this, all the different kinds of pulmonary hypertension up until now. We've mainly been focusing on pulmonary arterial hypertension. But as we've talked about, there is problem with pulmonary hypertension in the heart. And again, these are various types of patients. It can be older people. They can have diffuse scleroderma with kidney problems. That when you have kidney problems with renal crisis or very severe hypertension, that can put stress on the heart. Or again, this nucleolar pattern ANA. And then there can be other types of heart disease that can cause this kind of pulmonary hypertension. And also, cardiologists they don't get excited about pulmonary hypertension because the most common cause of pulmonary hypertension they see is this diastolic dysfunction. And I've had to really push patients' cardiologists to get them evaluated. Actually, the last 2 patients I made the diagnosis of pulmonary hypertension had been sort of poo-hooed by their cardiologist. Oh, there's a little elevation in your pulmonary pressures. Don't worry about it. Both of them had gone on to have increased pressures within the 6 months by the time I saw them. and had definite pulmonary arterial hypertension. So please check with several people, because as I say, I think some cardiologists who are used to seeing increased pressures in lots of people don't get excited about it. And this, we talked about the stiffening. And then we have the pulmonary hypertension that's related to pulmonary fibrosis. And this group of patients, we never had any treatment for it. Again, these are more common in patients with diffuse disease, more common in men, African Americans, and associated with the classic SCL70 or topoisomerase antibody. You hear that? Okay. And then lung scarring, I didn't turn my phone off. It's okay. Lung fibrosis occurs earlier in the disease and may require chemotherapy. And that is a clue that you might be at risk for later having pulmonary hypertension, particularly if you have low oxygen, if you need oxygen. And this is, in the past, hasn't been responsive to pulmonary hypertension medicine. As well as you have problems with lots of pneumonia and lots of other problems with that. But we now have a treatment for this group of patients. So the PH-ILD, or the group 3 patients, they previously failed studies with those endothelium medications. And when you give them IV medications, they get really severe hypoxia because there's a mismatch between the ventilation and the perfusions, and the patients get very low oxygen. Well, using this inhaled vasodilator, inhaled prostacyclin called treprostinil, the company did a study looking at patients with severe fibrosis and pulmonary arterial hypertension. And they were able to, in 26% of them, which is typical for pulmonary hypertension studies, 26% of them had connective tissue disease. So fortunately, all the studies that have been done in pulmonary hypertension are approvable for scleroderma patients. And so they looked at 6-minute walk, they looked at some blood tests, they looked at clinical worsening, and when they were able to show, even though it's only about 32 meters more than the placebo patients, it really was a significant improvement, particularly since all these patients were on dual therapy. They were also on medicines like sildenafil as well as an endothelium agent. And so then this led to the approval of inhaled prostacyclin or inhaled treprostinil or Tyvaso for the use of pulmonary hypertension in patients with pulmonary fibrosis. So now we have a treatment for that as well, which has really been a great improvement. So what does this mean for you? As I've said, you need to make sure you have your baseline pulmonary function test, and you need to know what your DLCO and your ratio is. And if you are at high risk, then you need to get your PFTs and your echoes done every year. If the echo is abnormal, then you need to have your right heart catheterization done. This is a very serious illness, but there's lots of treatment that is available. So in summary, lung disease is the most serious complication in scleroderma. All scleroderma patients need to be screened for pulmonary hypertension. Patients must pay attention to their own breathing ability and capabilities. There are lots of treatments for PAH, but it's really important to identify it early, treat it aggressively so that we don't end up with damage to the right heart that is irreversible. We have made PAH a treatable part of scleroderma, and that's really a great advancement in this disease. Thank you.